morning. Once again, a live demonstration from Seoul National University Hospital. I'm Hyo-Soo Kim. My guest is Dr. Sakura from Japan. He's really an excellent person for CTO intervention. So I'd like to be guided by him to perform CTO intervention for this case. My colleagues are Dr. Ki Yu-jung and Dr. Yang Han-mo, and many members. And later, I will introduce the faculty for IVUS interpretation. Slide, please. CTO intervention, plus 56 years old male, experienced chest pain for several months. Angiogram shows proximal mid-RCA CTO lesion. And my junior faculty tried antegrade approach 2 weeks ago, but failed, leaving several fourth channel. Plus, he is a really heavy smoker, 2.5 pack per day for 30 years. That is really important risk factor for CTO, stable angina, plus medication, and target is proximal to mid-RCA CTO, failed 2 weeks ago. Plan antegrade, ipsilateral retrograde, using such kind of wires. Plus, EKG shows a very small Q in inferior lead. Thus, this CTO, RCA CTO, would be a kind of viable myocardium. Plus, echocardiogram shows normal contractility, no world motion abnormality. Plus, left coronary artery shows proximal mid, mild to moderate lesions. Plus, RCA CT angiogram shows just proximal to CTO segment, there is a calcification, partial calcification. And the actual CTO segment is a little bit calcified, calcific nodule, calcific spot, but mainly it is not heavily calcified. Plus, 2 weeks ago, RCA CTO intervention was performed. We can see segment is about 20 millimeters. Ipsilateral collaters are dominant. The bad thing is, around proximal stump, there is several fine side branches. Plus, like this. That would be a kind of factor to let the interventionist misled to another direction. Plus, this is left angiogram, shows a little bit septal collector channels to RC, but ipsilateral flow is good, thus left coronary angiogram cannot show full distal RC. Plus, 2 weeks ago, first trial antegrade, using Sion, Gaia first, second, with backup of Courseware, the direction was wrong. Plus, side branch is a kind of hurdle to make a right direction. Plus, thus, there are 3 issues. Is there rationale for CTO intervention for these patients? What is the difficult technical point for this case? What is the feasible, best technical strategy for this patient? Plus, rationale, chest pain, symptomatic, normal myocardium, young age, thus we have to do CTO intervention. Plus, technical difficult point is shown here. According to JT score, these patients meet 3 points. A little bit calcified, long, and failed case. But on the top of these 3, I guess several side branches at entry point is a kind of hurdle. Plus, according to Korean CCT score, there is another factor, proximal adjacent side branches for this case. The total score is about 4, a little bit difficult case. Plus, How about best technical strategy for this patient? Antegrade approach once again with multi-channel microcatheter using UB3 Gaia series, or retroid approach first, expecting false lumens by previous failed attempt 2 weeks ago. Which collaterals? From LAD septal collaterals channel or ipsilateral collateral channel using ping-pong guiding catheter technique? Plus, here is the septal collaterals from left to right. It's not so prominent. Plus, but there's prominent ipsilateral retrograde epicardial collateral channels here. Plus, thus, I'd like to show you the angio taken just minutes ago. Angio, please. 이학승 선생, angio, please. Okay. This is LA view. There's no change of CTO segment and ipsilateral collaterals. There are fine several branches at proximal tapered stump. Plus, the area view. The point that I discussed, Dr. Asakura, is the morphology of distal true stump. There are some kind of stepwise morphology. Which is the true distal stump? Upper one or lower one? Minus, once again, you can see the distal stump is a little bit tricky. Plus, from left to right collaterals, there is several septal collaterals from distal LAD to PDA. Thus, is there any question or comment until now?
Any other comment about this presentation?
Well, while you are working, Dr. Kim, it's Eric Finkelstein again. I'm chasing you today. I think you raised all the questions, but I cannot ignore, and I don't want to be a fun spoiler here, but you know, the main slide I remember from a CTO session is why to do it, and there is a picture of Hillary on the Everest. He was asked, why did you climb the Everest? And he said, because it was there. Now, I'm asking this because you're getting into a tough case of CTO, and the patient is symptomatic. I don't know why, but I have an impression that he has a tight lesion in the diagonal, which is not a small diagonal, and he probably have significant lesion in the circumflex, and his symptoms could be there. Now, we're going to do the live case. It's a live case. But just for a matter of education, do you think you should first declare whether his symptoms is not from there and then go for the CTO in common practice?
That's a good point. Minus, is this the only image of left?
Yeah, only left.
Only image?
Slide.
Okay. Slide once again. They mentioned the lesion, significant lesion on the diagonal. So please show the LA left system. Okay. Diagonal segmental stenosis there. Yeah, there. But I think RCA is very big. Circle is very small in this case. Thus, I think contribution of RCA is very, very definite. So from my experience, when I open the CTO segment like this, young age, there are three phenomena always I reported. The first one is disappearance of any discomfort. Second, warming up of cold hands and feet. Third, potentiation of erectile function. So I think Of course, the myocardium well accommodate to such kind of CTO lesions, but actually when we open those lesions, there's whole change of life. Thus, I always try the CTO intervention, then see the patient improvement, then we can decide other minor lesion treatment. But I think in such kind of, I say, dominant case, definitely CTO is required.
Any other comment?
Okay, plus...
If you remove the Dr. Finkelstein's comment, you'd better to have some evidence for the objective ischemia. What I mean is the cellium scan or the other evidence.
It's okay. We are convinced. We want to see your. No, it was just educational, Kim.
Okay.
We want to see your strategy. What do you plan to do?
Thus, I try to do retrograde approach because there is eminent epicardial ipsilateral collector channels, because there must be already a false lumen antegrade. Thus, I tried the retrograde and then antegrade, both grade.
Actually, sorry, continue.
Let me show the progress that we have taken, plus.
Before that, I'd like to have some comment from your commentator, Dr. Akasakura. I know he's the real expert about it, his treatment of strategy in these cases.
Most of the time, I start to use septal channel in such kind of case. But in this case, LAD is diffusely diseased, and also PD branch is not so big. So in order to avoid ischemia, I totally agree with Dr. Kim. Epicardial channel is better.
Okay, this angiogram shows the initial entry of Sion wire into epicardial collaterals from areocranial view, plus. Then I advanced the Sion wire, plus. Then I advanced Caravel. I met the first tortuosity, Sion wire struggle, plus. Then another angle to spread the tortuous vessels. I did tip injection. Luckily, there is no damage, plus. A little bit withdraw the Caravel once again, plus, once again. Then I remember the true pathway in this angle. Thus, from now on, I'd like to advance the SO3 plus. First, wrong direction, probably. Zigzag is good, sign. Plus. Okay, more advanced. Then we entered straight segment like this, plus. Distal RCA, mid RCA, plus. Okay, mid RCA, just distal stump, plus. Then I advance Caravel gently, not difficult. Without rotation, just gentle push with pulling of the wire, plus. Then I check the antegrade angio to localize proximal and distal stump. Here is the tricky point of distal stump. Dr. Asakura suggests the wire tip is a kind of side branch of distal stump. So actual distal end of catabel is true distal stump. That is very tricky point in this case.
Do you have CT data?
Yeah, on the slide I showed the CT data. Okay, once again slide, CT slide. 슬라이드. 금방 아주 좋았는데 왜 바꿨어? CT. Okay, I see. This is a slide. So when we see the distal stump, it looks straightforward. So the angle section, CT section is not well correspond to the such kind of tricky morphology of distal stump. Okay, angio, please. Then I insert the ping-pong guiding catheter system and plus I did retro microcatheter injection to clarify the distal stump, but it did not helpful. It does not help. Plus, so I inserted the antegrade system, Sion with Corsair backup, plus, then I advanced Gaia first. The lesion was too hard. Thus I changed Gaia second. A little bit right side direction because previously left side direction was wrong. So I intentionally avoid previously made force lumen. Plus, on RC, the angle is good. Plus, but at the final point, I think there is subtle difference in the orientation between retro microcatheter and ante-Gaia second wire. Thus, from now on, I'd like to do retrograde wiring. What's retro wire? Gaia second? Okay. From now on, it's real live. 아래요. Okay, AP direction is good. LAO. So I'd like to maintain the direction on the right side of vitro wire. Resistance. I advanced retro microcatheter to enhance the backup force. Okay, there is movement. More close to previously failed course. 저장하고요. 아래요.
So Dr. Kim, that is Gaia second from the
AP direction is good. Okay, please.
Dr. Kim, there was a question about the wire that we are using right now.
Gaia second, retro. Ante Gaia second, both Gaia second. Okay, LAO. Okay, ante test 준비.
Dr. Kim,
Yes.
okay. What are you doing?
Okay. Do you see the angel? So we
Of course.
now ante-wire, left retro wire casing. Then we try to retro or ante-ballooning to do reverse cart. But the problem is RCA backup is very poor, plus. Thus, I tried to put the retrowire into true anti-lumen. It looks good, but plus. Direction is deviated. So I tried to perform anti-ballooning for reverse cart, but backup is very poor, plus. And lesion is very hard. This balloon cannot be inserted into CTO segment, even with 1-0 balloon. So I tried to advance anti-wire into distal true lumen like this, plus like this, plus, plus. So I confirmed the anti-wire into the distal true lumen like this, plus, plus, but plus. Anti-guiding is very poor. Thus, it is plus disengaged. So I start again anti-wiring.
How about use the AL1 anti-guide?
The first guiding catheter was R1, now Judkin. AL1 is a good option, but this is a ping-pong system. Thus, already engaged guiding catheter is a kind of hurdle for the best engagement of right guiding catheter.
So I mean that you already engaged the AL1, so try anti-wire via the AL1, not use the ping-pong technique.
Okay. So I gave up ping-pong technique and I introduced.
May I ask the opinion of Dr. Asakura in the current stage? What is the best option?
Yeah, my answer is also AL1. I think 620 is okay.
So from ping-pong system, just alone system, the single guiding catheter system. But the guiding catheter orientation is not good for the introduction of stiff wire. Okay, this is a kind of friction. Not good. Soft wire 해도 들어가서 할까? Okay. It's compatible 2-wire in 7 French? Okay. 이게 들어갈 수 있다 이지? Another 그게 말고 백업이 들어갈 수 있냐고. 어? 카테터 들어갈 수 있냐고. 7 French 2개. Okay.
So this would have been a good case for even ADR with Stingray. And you already have the integrate wire almost all the way up to the mid portion, which is really nice.
But problem is poor backup. We cannot proceed cross pulse. Okay, this is a microcatheter. Microcatheter, 장착을 안 했구나. 장착했어, microcatheter. C-on wire cannot pass, cannot advance. Thus, ping-pong technique is more appropriate for left main. ICL stem is narrow. 뭐 하노?
왜냐면 삼성은 거의 다 끝났으니까 얘기하고 나머지 시간에 갖다 교수님 지금 한번 얘기를 한번 얘기해 보세요. Maybe change because it takes time to solve.
Okay. Just we insert corset back up using extension catheter. We have to save the balloon, so balloon anchoring is actually impossible in Korea. 자, 잡았어? 자, 오케이, 텐션. 자, 보고 Y가 폴랩스 되는데 들어갈게요. Okay, Y exchange to Gaia first.
Dr. Kim,
Yeah. Deflation.
what are you doing now?
I passed the wire into this true lumen, so I now doing ballooning. 자, inflation. Deflation. To save the balloon, I tried to use the balloon several times. Inflation. Deflation. 세 발론을 줘야 될까? 디스탈에 아까 1번은 넘어갔는데 2번은 안 넘어가네. Inflation. Deflation. Okay,
Dr.
2.5
Kwang,
second.
what kind of wire at this moment? Dr. Kim.
Minus. So I passed the wire and checked the anti-wire into true distal lumen like this by injecting dye into retrograde microcatheter. As Dr. Seung-Wan Han suggested, it is good strategy to make backup strong using just a single guiding catheter system rather than ping-pong technique. With this technique, I can pass the wire antegradally and finally put in the wire into distal true lumen. Here is another resistance. 야, 1.0 발론을 하면 돼야 되나? Okay, inflation. Deflation. Inflation. 야, 그 디스탈 그 딱딱하네. Deflation.
Dr. Kim,
Yeah.
hi, it's Eric again. While
Inflation.
you're working, I want to have your opinion. You know, one of the devastating and frustrating complication of this retrograde, what you did right now, is problems in the left main. So you're very happy, and then you have the procedure, you are giving injection, and bad news, there is a problem in the left main. Now, you have experience with it probably. What is the measures? What's the measures that you are taking part in order to prevent this?
No, he's not in the left main. He's both.
No, not now.
Yeah.
Before. In the beginning of the procedure,
Oh, okay.
when you are doing when he was doing the retrograde in the beginning, one of the problems that we're facing is problems in the left main, if you don't take good care about it.
All right.
And I'm asking him because he's experienced, what measures does he take in order to prevent that?
Okay.
But he's too busy now.
Yes.
To prevent leakage using epicardial collateral channels,
No, Dr. Kim, Dr. Finkelstein's question is if you have to do it through a channel from the left main, LAD or septal collateral, what protections do you take to make sure that LAD is not dissected, or how do you protect it? I mean, not in this particular patient, in general.
yeah, the most important step of such kind of intervention is externalization. Wire when you externalize RG3 all around the heart, you have to maintain the attention that there is a strangulation of left coronary artery, septal collaterals, and right coronary artery. Another important situation is to when you remove the RG3, please don't make a tension. Then make a kind of laceration injury to the septal artery or other. And at that time, the guiding catheter are deeply engaged. Thus, that may cause left main ostial dissection or ICA ostial dissection. Thus, always when we use RG3, there is two very important steps that you have to pay attention to avoid damage. Thus, I like a Langdeb technique. When the retrograde wire is into antegrade guiding catheter and retromicro catheter into the anti-guiding catheter, then you insert anti-wire into retrograde microcatheter inside the guiding catheter. Then you have to avoid RG3 externalization. That is a technique called as Langdeb technique.
That's exactly what I wanted to hear, and that's very, very important and educational.
Yeah, okay.
Thank you very
Best-
much.
So, Dr.
Deflation.
Kim, I noticed that you have your own radial skirt. Is that
Yeah.
some modification of your own, or is it? Can you show it to us when you finish all this?
Yes, please. Yes. then 다시 한번 2.5. This is a kind of half drum made of lead to protect whole body, including ankle. So I spent my life doing intervention for more than 20 years, so I'm an abandoned person, but my junior faculties are really kind of young doctors that should avoid the excessive radiation exposure. Thus, I ordered the purchase of this drum. Okay, that's good. Inflation. Deflation. Maximum.
So far, you are doing multiple balloon.
Yes. Plus deflation. Inflation. Deflation. Inflation. Deflation. Inflation. Dr. Han's suggestion was right. Plus deflation. Backup problem solved. Okay. Angiosine. Okay, we can see the whole pictures. Then we provide IVUS image for you. 포지됐죠? 네, 갑니다. 잡았어요. Okay, on. Here is distal through segment. Vessel size is about 4, MLD is 2.5 with huge concentric plug. Pullback.
There is a hematoma in the 12 o'clock to the 3 o'clock. And calcium.
This is calcified CTO segment.
So, what size of the stent for this lesion?
proximal 3 or more, then I can decide the distal morphology. I see the distal morphology and decide which size, which length. Here's proximal true lumen. Vessel size is about 4. Thus, proximal segments should be treated with 3.5 or more. This proximal lesion, MLD, is about 2, less than 2, 2.5. Lumen is about 5. This is free. Icosis, this is free. Okay.
So what size of the stent, what type of stent, what length?
We are now doing a host idea RCT where we try to compare the 3-month versus 12-month DAPT, especially in ultra-stenting, ultra-thin strut stenting. In other words, O0 or IZAR, the strut thickness is about 70 or less. Thus, with such kind of thin strut stent, I'm sure that 3-month DAPT would be enough in all comers. Thus, this patient is enrolled in host idea. Thus, I try to deploy the longest O0, 3.5, from the RCA ostium, just distal to the now the retrograde microcatheter. 바꿔야지.
40, 30,
No, 3.5.
35. Okay.
소프트웨어 주면 패스할게.
Okay.
한테.
Please deploy the stent.
카라벨로 가져올까?
Can I talk
Okay,
about-
first I'd like
Can I
to
talk
exchange the stiff wire to soft wire to protect the damage on the PL branch, peripheral PL branch. Thus, first I exchanged the Gaia second to the soft wire. 뭐 한다고?
Hi, Dr. Kim.
Yeah.
Thank you for your teaching procedure. This is Kazuki Mizutani from Japan. I recommend the check up the channel injury before stenting. In this case, we do not the externalization. So if channel injury occurs, we cannot stop the bleeding
Yeah.
after stenting.
Okay, so I try to make sure there is a patency or no damage on the epicardial collateral channels. 잡았어? When I remove the microcatheter. 오케이. 자, 뺄게요. 자, 소프트웨어 좀 준비하고요. 네, 소프트웨어하고 익스텐션.
Integrate wire pass through.
오케이. Okay, I exchanged the soft wire, Gaia to soft wire, and Once again, we try to take a picture. Okay. 살짝 테스트 해볼까? Okay. 자, 스냅. 3.5 longest.
3.5, 45.
The strut thickness for Osiro is about 70. If the stent size is less than 3, it is 60s. Thus, the healing process would be very fast. Thus, I'm sure that 3-month TAPT would be enough for all comers.
Yeah, there are a lot of new stents coming up with thinner stent struts as well. I mean, even in India, there are 2 companies which are making 50 and 65 micron stents.
Okay.
Yeah.
자,
This is
테스트 한번 볼까요?
30.
What length of it? Do you want to fix it just a single one stent?
No, just I want to put the first stent, then see the distal morphology and decide the second stent. Before stenting, I try to remove the retrograde microcatheter, as shown here. 오케이, 저장하고요. 테스트 한번 해볼게요. 테스트, 슛. 오케이, 그 저장하고요. So I removed the collateral microcatheter fully. Okay, 다시 쓰네. 슛. Channels are patent good. Then I put the stent a little bit proximal. Okay, 테스트 준비. 테스트. 테스트. Okay, inflation.
8입니다.
테스트. This is CTO segment. Thus, I inflate the stent for a prolonged time. If patient tolerable, I always inflate about 40 seconds or 60 seconds to fully let the strut oppose to the wall. Prolonged inflation is very important. Forty seconds. Okay, deflation. A little bit withdraw and maximum pressure. My habit is nominal prolonged inflation, and then I pull the balloon a little bit proximally, then perform a maximum inflation. Maximum inflation. Like this. Deflation. So please wait. When you retrieve the under-deflated, incomplete deflated balloon, the guiding catheter engaged, and there is a longitudinal shortening deformation of stent, especially in such a thin strut stent. Thus, please remove gently the deflated stent balloon. Okay, stent scan. N점 줘볼까요? So I always use nitroglycerin intracoronary fully because of full dilation of distal segment. 자, 쓰는 준비. 자, 크라니아 조금 줘볼까요? 스탑. 오케이, 스탑. 방향 안 좋은데. 카메라에 쓰네. Then I'd like to deploy the about 2.75 stent.
Where?
Distally.
Cranial, cranial. Stop. 쓰네.
Where will
Probably
be the distal landing zone?
this landing zone where? Minus. Where do you recommend? All mildly diseased. Short stenting or long stenting covering distal RCA? How about the junction between mid and distal? It's a little bit disease there.
I think
Plus-
the angiographic appearance is a little bit different. What I mean is that just the distal to the distal stent margin is maybe the distal end of the CTO segment, and the more far distal segment is underperfused segment. So if you plan to deploy the stent another distal to the stent, I think you need measure the actual vessel size. Usually, if you deploy in the proximal stent 3.5 distal, 4 case for the RCA, 3.5 is quite enough. If you want to know about it, do the IVUS once again. Actually evaluate the size of the distal vessel once again.
Okay.
I
IVUS
prefer shorter
shorter.
because there may be negative remodeling of the distal vessel. You can wait and see.
Okay. So once again, nitroglycerin. 잡았어요. NG 주고요. I will introduce once again intracranial nitroglycerin. Okay. Okay, here is distal RCA. Okay, prepare.
When you look at this part, what is the vessel size?
Vessel size is about 4,
Yes.
3.5.
You know that the
Angel voltage,
RCA is no tapering from the proximal arcing of the RCA to the distal bifurcation to the PDA and posterolateral segment. It's a no tapering conduit. So if you deploy the 3.75, it's too small.
Dr. Kim,
Yeah.
don't listen to him, trust me. I mean, the artery is not always read the book and the IVUS. There is a huge plaque there, which is pretty old and calcified, etc., etc. You don't want to over-dilate it and finish a beautiful case you've done so far with a catastrophe. So don't be greedy. I would put them something much smaller. If you're taking a 2.5, you can enlarge it to 3.5, right? So start with a 2.5 over 15 something millimeter. Look at it, give nitro, do IVUS, whatever you want, and then you can post-dilate and do a trumpeting to the proximal part. I totally agree with Dr. Hong. The RCA is a conduit. It's not tapering. But the atherosclerotic part, plaque is not consistent all in the whole artery. So that's why the distal part is much, much smaller.
When you look at the ibis distal part, is a full vessel, is a lot of the plaque burden, but just the distal to the stent segment, there is still hematoma and some dissection. So it should be covered. Anyhow, it's maybe different. What is the distal part is the diffusely the atherosclerotic segment, but in the just to the distal segment, distal to the stent is the injured by the balloon or part of the CTO segment.
I think it's probably better to just take a short stent, not to oversize too much, and bring the patient back in the future to just do an angiogram to see how much of the negative remodeling has disappeared. I think you have done an excellent job in getting this result so far.
I think the 2.75 and the short stent is a good choice for this patient.
Okay, this is RCA austere. So stent apposition was good. So prolonged inflation, then full expansion is kind of effective. Okay, I adopt 2.75 short stent.
Good.
How short?
Now do it fast because you got 3 minutes
Okay.
to show
Okay.
us.
You know, the longitudinal view of the ibis, you can clearly see some length of the injured segment.
얼마? 마이너스?
Ariel, it would be also nice to see how many in the audience would put
2.75
a
에다가
275 or a 40.
마이너스.
We will do both. It's a good.
이 얼마?
Okay.
No, I mean,
20?
he's in a minority here in the podium. Well, what are you talking
No,
about?
In the
we ought to
audience,
know.
will anybody put
21,
40?
23,
40 stent distally, lift your hand.
23, 24?
Is there anybody in the audience that think that he should put a 4.0 stent in the
Distally.
distal vessel?
3.5.
3.5, raise your hands.
You're trying your best, right? Oh, you know what? 3.5. Is there anybody who thinks so?
One hand came up. 3.0? 2.75? Actually, so many votes for 3.0 actually.
You lost.
It's okay.
Come on,
it's
come
okay.
on. It's okay. You lost.
I'm happy what I know because most of the audience don't know about the real fact. I'm happy.
없어?
How about a short stent versus
23
long
없어?
stent? Short stent, raise
22.
your hand.
아, 참 답답하네.
What length? The
22.
based on the ibis?
Length is 22 or 20.
Okay.
Just 20.
If we
You should
make
add
if we
more
make a 2 millimeter
2 or 3
overlap,
length,
then the
more
distal length
longer
will be right
length.
here for a 22 stent.
Okay. 답 넓네, 영민이. Okay, we decide 2.75 by 22. And nominal pressure prolonged, and then a little bit retrieve and at maximum pressure. 잡았습니다. 약간 카우더를 해야겠네. 안 보인다. 스탑. 테스트. 자, 시내 안 할게요.
Okay, Dr. Kim,
Yeah.
time is over.
Okay, inflation.
Okay.
Okay, you have 1 minute to show us after the
Yeah.
stand the results. We want to see that.
Just the branch.
We want to see whether Dr. Hong is going to be satisfied.
좀 더 올리고 12. Okay. Deflation. 조금 빼서 maximum. Okay, maximum. 16. 네, 저장하고요. NG 주고 deflation.
So much of black burden. Even if you put
NG.
where is this class going to go?
So I introduce NICNG once again, and then final NG.
Probably
약간 쿨하냐?
to do it.
조금 더 LAO 더 해주고. Stop. 오케이. 쓰네. 아리오 카우다.
Excellent,
These
excellent.
are the comments.
Congratulations. We will close this session.
Yeah, this strategy is natural. Yeah, your recommendation was right. Thank you very much. See you afternoon.